Good evening, everybody, and welcome to this tonight's session. First and foremost, I'd like to thank all of you who are spending your evening here for the next hour and a half or so, giving us the opportunity to introduce you to the UCCRI, what this institute stands for, and what we're hoping to accomplish, and how you folks and those that you know could potentially help us. So before I go on to introduce the faculty for the evening and the session, just a quick background on the UCCRI. So this is the Urological Cancer Centre for Research and Innovation, which is effectively a entity at St. Joseph's that was put together through efforts by Dr. Kapoor, who's on our faculty tonight, along with a hospital and the foundation, with the ultimate goal really being to look after patients clinically, to advance education, research, and innovation in the area of genitourinary cancers. And prostate cancer, along with bladder cancer and kidney cancer, are is the focus essentially of this organization. And none of this would exist without the generosity of many benefactors, and many of them are online tonight. So tonight we're going to launch into a discussion on prostate cancer, really just to give you folks an overview of what's happening today. This talk is going to be broken down amongst the three faculty here tonight. So I'm just going to briefly introduce the three of us. Dr. Matsumoto will lead the initial discussion. Dr. Matsumoto is an associate professor of urology and surgery at McMaster University in Hamilton. He's held numerous positions in leadership, in education, research, as well as resident training. He'll talk to us tonight on the early stages of prostate cancer, particularly screening. And I think this is something that's of interest to everybody. I'm another uro-oncologist also in Hamilton, and I'll be discussing kind of a bird's eye perspective of prostate cancer. And then Dr. Kapoor will conclude by filling in all our gaps, of which I'm sure we'll leave many, hopefully not. And Dr. Kapoor will also focus on advances in radiation treatment, as well as some drugs, and any questions you'll have. In terms of questions for housekeeping, it's really not easy on a Zoom to have a verbal back and forth discourse. So I would strongly suggest that any questions be put out through the Q&A function that's at the bottom of your Zoom screen. And throughout the talk, I'll be monitoring the question. And what we'll do is we'll go through all the three talks, and then we'll try and address the questions. Of course, all of this will be much more interactive if questions are placed out there, and we can have a nice discussion. So with that said, I'm going to pass the baton to Edward Matsumoto, who has been a faculty here for, I believe, 17 years now. Is that right, Eddie?
Yeah, that's
17 years. He's getting old, but he's Asian, so his hair color does not change. It's been that color the whole way through.
Yeah.
So Eddie, thank you very much, and please go ahead.
All right. Thanks, Bobby, and thank the foundation for supporting this. And let me see if I can share screen here. And so I was tasked with giving a talk on prostate cancer screening. So this is obviously something that's very important for men. Obviously, men that have history of prostate cancer in the family, something they have to really think about. I want to kind of give you an overview of this. And so these are some of the questions that we'll try and address with my talk anyways, is what does the prostate do? I think that's a good question. We talk a lot about prostate, but a lot of guys really don't know what the prostate does, other than it causes a lot of headaches and problems down the road as they get older. What is prostate cancer and how do we screen for it? So this is the prostate. It's a gland. It's only found in men. And once again, this is my big thing, is it's not prostrate, okay? This is prostrate down below. So where is the prostate? So this is a gland that is located between the bladder and the urethra. And you can see the big yellow arrow there that points to that. And you can see why it can cause a lot of problems. It sits between the bladder and the penis. So if it gets bigger, you can have problems with urination. And obviously, if it becomes cancerous, it can cause a problem by spreading into different areas of the pelvis as well as the rest of the body. there are certain structures that are also associated with the prostate, and one of them is called the seminal vesicles, and these are two paired organs that sit right behind the prostate, and this produces much of the ejaculate fluid. And he also has the vas deferens, which come from the testicles, and that delivers the sperm into the prostate along with the ejaculate fluid for fertility. So when we talk about prostate, the prostate can be categorized in various diseases, and the two main categories, benign and malignant. And for tonight's talk, we're really going to focus on the malignant part, which is prostate cancer. So prostate cancer is very prevalent in our population, meaning that it is found in fairly high numbers. You can see here, this is a 2017 statistics. Roughly 21,000 men are diagnosed with prostate cancer. And it's really the most common cancer that is found in Canada and North America. And there are approximately 4,000 men that die of prostate cancer every year. So this is one of the highest causes of cancer deaths. It's the third highest. Fortunately, if you're diagnosed early, the survival after for any kind of treatment is actually quite good. It's about 95%. So when there is a cancer that's so prevalent in our society, we want to be able to screen for cancer. And men over the age of 50 should discuss the benefits. Of course, there are some risks associated with prostate cancer screening. And the way we screen for prostate cancer is through two different tests. One is a PSA test, which is a simple blood test that's available in virtually all labs throughout Canada. And then the other is a digital rectal examination, which your family doctor should be doing every couple of years. And men that have a higher risk, that is, if they're African American or if they have a family history of prostate cancer, should consider getting the PSA screening done earlier. Unfortunately, prostate cancer screening has met with controversy in the past. And a lot of it has to do with a misunderstanding of studies, and the major issue right now, I think, is family physicians have not kept up to date on guidelines. I still, to this day, hear patients complaining that family doctors do not believe in PSA, which really is nonsense. A lot of this controversy started back in 2008 when this organization called U.S. Preventive Services Task Force came out with a grade I recommendation for PSA screening. At that time, they said, well, we don't have a little bit of data, so we can't really make any kind of comments or any recommendations. And then a few years later, after a few other studies have came out, they actually came out and said it's a grade D recommendation against PSA screening. And this actually initially came out with a lot of fanfare. A lot of social media picked up on this, saying that PSA screening caused more harm than good. We should stop doing this. And this created a big uproar in the urology world, because we truly believe that this was not the case. So here is a nice graph that illustrates what's happened with prostate cancer diagnosis over the years. Whoops, I lost my screen here, sorry. Can you see my arrow? Yeah, you can see, okay, so you can see here, this is the kind of the pre-PSA era, before the 1980s. And around mid-80s to kind of late 80s, this is when the PSA was introduced. So all of a sudden, you have all these primary care physicians starting to do the PSA testing. And with that, we see a rise in the incidence of prostate cancer. So you see this little blip here. So we catch up on all the patients with prostate cancers out in the population. Eventually, it just drops off, and you start tapering down here. This tapering effect is not the fact that the actual true rate of prostate cancer come down. It's the fact that the PSA screening has gone down over the years as well. This is another graph, and this is a real important graph. This shows the mortality rate of prostate cancer. So this, you can see here, once again, it somewhat peaks, very similar to the PSA screening, maybe a few years later, where you see an incidence or the mortality rate rising, and it stops dropping. A lot of this feel that this is related to the screening, because really treatment has remained the same for the last 10 or 15 years, in this era. But then what's scary is towards the bottom here, you see a drop and actually a flattening of prostate cancer deaths. What we're starting to see now is a slight rise. And this slight rise is causing a lot of concern amongst a lot of epidemiologists. This was a GUASCO paper that was just published not too long ago, actually just this year, 2021, which actually showed the incidence. Once again, this is the number of patients presenting with metastatic prostate cancer has actually increased between 2008 and 2016. Once again, if you recall, that original recommendation kind of came in around 2008 to 2012. So this is the same time when they started recommending PSA screening was causing a lot of harm. Well, what's happened is we actually see more men presenting with metastatic prostate cancer. And of course, this group also looked at the drop in the PSA. In primary care, the PSA screen dropped from about 62% to 50% during the same time period. So there's no question the family doctors, the primary care physicians in North America heeded the warning or the concerns of the U.S. Preventive Task Force and stopped doing the PSAs. Well, this is what we're seeing now. What we're seeing is, once again, this is the incidence of stage 4 prostate cancer. So this is patients that present with cancer that is actually spread. So you see, once again here, you see this rise up until about kind of the early 90s, okay? Then you see this drop off. Once again, we feel this drop off is due to the prevalent use of the PSA screening kind of in the early 90s. But then once again, once we made the recommendation, stop doing the PSA screening, you see this slight rise. And this rise is very concerning because if you look at all other cancers during this time period, ovarian, colon, breast cancer, all these cancers have witnessed a drop in stage 4 and more importantly, deaths related to these cancers, except for one cancer, and that is prostate cancer. And this is causing a lot of alarm and concern amongst higher ups when it comes to seeing this type of data. When it comes to studies, we have some good studies out there that actually tell us that prostate cancer screening actually works. And you know, the group that came out with these guidelines, these recommendations, had access to these studies, but what's happening is these studies are maturing. We're starting to get a better understanding of what these studies are telling us. So these are essentially organized into two studies. One that was done in North America. Usually, really, it was just a single country study, which is done in the U.S., called the PLCO study. And then there was a much larger multi-country study that looked at PSA screening in Europe. This is felt to be the better study. It was much larger. You can see here it was 76,000 men versus 160,000 men. And most people understand that the larger the study, the better or more robust the data is going to be. And what this study showed was that there was actually a 20% reduction in prostate cancer deaths related to when you have screening involved. And most urologists really, really believe this data. The American study showed that there was no difference, partially because this was not a very good study. There was what's called cross-contamination, meaning the arm that was supposed to be the control arm, that is not supposed to be screened, about half of that group went and got screened anyway. So you can imagine that would impact the actual result itself. The Goldberg study was a subset study of the European study. And this was felt to be even a tighter study and with better results. And you can see here, there was actually a 44% reduction in prostate cancer deaths with this screening study. Anything in cancer, if you see a 10% reduction, that is considered an impressive result. So we have two studies here that show a 20% and 44% reduction. So once again, we actually have evidence that shows that screening has an impact on prostate cancer deaths. So the next question is, well, it seems like prostate cancer screening is effective. What about treatments? Well, this is an area that's been studied very well. And there's basically 3 trials that are still ongoing. The Scandinavian study, this is actually quite mature. This looked at radical prostatectomy versus watchful waiting. And this study showed that by 23 years of follow-up, around 3 years of life was gained with patients that actually underwent surgery. Similarly, in the ProTrack trial, patients that underwent radical prostatectomy compared to those that had watchful waiting had better survival. Okay, and the numbers here, 27 men needed to treat with radical prostatectomy to prevent 1 man from metastases at 10 years. These numbers are almost identical to breast cancer surgery data, okay? And that's pretty much well accepted, is breast cancer screening and breast cancer surgery has an impact. And then finally, and once again, this is a study that has not really matured yet. This is only 10 years out. So I suspect once as we follow this data, it's going to mature. It's going to clearly show that the surgery does have an impact on survival. The pivot trial, very similar results, 20 years out. Now, this was basically all comers. They had patients that were watchful waiting that probably should have been in the watchful waiting arm as well. Overall, the study showed there was no difference, but what it did show was patients that had intermediate risk, those that had higher risk cancers, did much better with radical prostatectomy when it came to survival. And the relative risk reduction was 14.5%. Once again, 50% reduction in deaths with surgery alone. So that's a very select group. But in fact, that is the group that we tend to select out. Bobby will probably talk a little bit about who we identify as a candidate for surgery. So with all this information that came out in the last, let's say, 5 years, the U.S. Preventive Task Force fortunately came back and made some changes to the recommendation. And they said, well, let's make it a C recommendation, meaning this is what we had before, that this is something that could be discussed. But guess what? Yeah, exactly. Crickets. No media picked up on this. No social media, no newspaper articles, no Newsweek, Time Magazine articles. So guess what? Family doctors, primary care physicians did not hear about this, and they still practice based on recommendations that are made back in 2008, 2012. And that is what makes it very frustrating. So what do Canadian urologists recommend for screening for prostate cancer? Well, what we recommend is doing what's called smart screening. This is put on by the CUA, and we recommend looking at screening for men that have at least a 10-year life expectancy. So as you can see here, it's not a real age cutoff. So you could be 70 and you could be in excellent health, and it'd be quite reasonable to look into PSA screening, especially if you have longevity. Your father lived to age 90 or 100, who knows, right? I think it's quite reasonable to look at or discuss PSA screening with your family doctor. But in general, we suggest starting at age 50 for most men that are healthy, and age 45 if there's an increased risk of prostate cancer. So that is if they're African American or if they have a family history of prostate cancer. So this is some breakdowns on how we recommend doing PSA screening. And based on your PSA level that you initially present with, this can stratify you in as far as the intervals of the follow-ups. So if it's quite low, less than 1, they just recommend doing a PSA every 4 years rather than every year. If it's between 1 and 3, they recommend doing it every 2 years. And if your PSA is greater than 3, they recommend doing it yearly and using what's called adjunctive testing strategies. I won't get into that, but there are some other PSA tests that we can do to really kind of help us refine our ability to detect or rule out prostate cancer. As far as, what age do we discontinue? Well, the CUA actually recommends if your PSA is less than 1, you could even discuss, discontinuing PSA screening at that point. For all other men, really consider discontinuing at age 70. And of course, men with age or life expectancy less than 10 years don't really have to talk about PSA screening. You have other issues to worry about. So the take-home message I have for men out there is that there is very good evidence to show that PSA does help improve survival for prostate cancer. DRE and PSA are really our first-line defense and screening for prostate cancer. And for family doctors out there, hopefully they will get this information. We try to be vocal as much as possible. I think it's up to a lot of our patients to be advocates for themselves and to talk to the family doctors about PSA screening as well. And that just kind of summarizes what we have there. Do I have some time still or?
Yep.
Yeah. Okay. I don't know if this video works or not.
Manolis Santanos.
Okay. Let me just explain this. So Manolis Santanos is he's a comedian. We did this video, this is probably about 10 years ago, and it's kind of a funny, this was during one of the prostate cancer awareness months in October a few years ago, and he approached me. I look after his father. He goes, I want to do this thing on prostate cancer, and he said, okay, well, we'll do this thing. So we videotaped this one night, and I thought it was quite interesting. So anyways,
at St. Joseph's
can you guys hear that?
Today I'm going to see Dr. Matsumoto. He's going to check my prostate. I'm not looking forward to it because it's back there. All right, let's see what happens. I'm really not looking forward to this. I can't believe I'm in a hospital. And what if they find something? Then what? I can't believe I'm doing this. I don't even know what prostate is. I don't even know where it is. I don't even know if it hurts. What if it hurts? He does this and he goes, oh my God. How did you talk me into this? I have no idea how I am in this situation right now. Is it too late? Can we not do this? Can we just, I go all my life without having another person's fingers in my butt. Fine, we'll do it. Fine. This is Dr. Matsumoto. What do you do, Dr. Matsumoto?
I'm a urologist.
What exactly does a urologist do?
The easiest way to put it is we're plumbers. So we look after the plumbing. So we look after the kidneys, the ureters, which are the tubes that drain the kidney, the bladder, the prostate.
Where's the prostate exactly? Because I'm not even sure.
The prostate is a walnut-shaped organ that's found between the bladder and the penis. The prostate examination is done through the rectum because it's immediately adjacent or right beside the rectum. So that's just right inside the anus. You can actually feel the prostate right there.
How many fingers do you use?
This is the one that goes.
It's only one?
It's only one. And this is for a second opinion.
So who should be getting a prostate exam?
Men over the age of 50
Okay.
with at least a 10-year life expectancy should discuss getting a PSA and a digital rectal examination with their family doctor. And that should be done on a yearly basis.
Oh my God. Every year?
That's what's recommended, yes. And if there's a family history, your risk is higher as well. So for that reason, they recommend starting at an earlier age. So on average, we suggest starting at age 40.
Do you mind?
You my guess?
Actually smells pretty good considering.
Okay, Manolis, we're going to get you to the gown, opening to the back. When you're ready, just open the door and I'll come in and we'll do the examination. Okay, all ready to go?
Yeah.
Okay, let's do it.
Sorry, I'm nervous.
Not to be nervous about it. So we'll get you to just lean on this table here.
Should I be spreading my ass cheeks or do you
Just relax and we'll look after everything back here. I haven't done anything yet.
Oh. Okay, sorry.
Nice deep breaths. Okay. And here we go. Oh. And we're done. We'll give you a little wipe here. And we're finished. That's all there is to it. You did very well, my friend. It wasn't that bad, was it?
No, I guess not. Okay, Doc. A moment of truth. I need you to shoot me straight. Am I going to be okay?
Manolis, you're going to be fine. Your prostate felt normal. Nothing to worry about, my friend.
Okay, cool. Just another thing, though. You know that lube you used on your fingers? Back there's still feels a little kind of squishy back there.
Make it a point for next year. Have a good year.
Thanks, Doc.
Anyways, I thought that's kind of a fun. It's really not that dramatic. It's really not that bad. So talk to your family doctor. Make sure they do the PSA screening. And I will end on that note. And I said we can hold some questions, I guess, till the end. I think that's what the plan is, right? So it gives me great pleasure to introduce my colleague, my partner, Dr. Bobby Shayegan. He is the head of a division of urology at McMaster. He's also an associate professor. He's also holds the endowed chair, the David Braley, the Nancy Gordon chair. He's also the director of the McMaster Institute of Urology. He wears a lot of hats. He is our uro-oncologist. He's a deputy chief of surgery at the hospital. He's involved with Cancer Care Ontario. He's also chair of the robotic surgical program. He has many publications in the world of uro-oncology, and he's a great surgeon and a great friend. So without further ado, I'll introduce Dr. Bobby Shayegan. He's going to talk about prostate cancer treatment, I think, right, Bobby?
Yeah. Thanks very much, Eddie. That was great, and thank you for that great discussion on the front end of all of this. And I'll come back to this at the end. That's actually what probably matters the most. You know, we talk a lot about, you know, in public health, people talk about primary prevention, secondary prevention. In the cancer world, if prevention is not an option, and it does not appear, at least currently, that prostate cancer can be prevented, perhaps the best we can do is identify early and then treat them on that basis. And I think Eddie pointed out just how far we've gone wrong there in the last decade or so. So to give you guys an idea of this journey, Dr. Matsumoto started off here saying that, look, effectively, sorry, this should be reversed, that men are at risk, which is effectively all men by the time we hit 50, but there may be cohorts of men that are at higher risk up front. Like, you know, Dr. Matsumoto talked about those with a family history, perhaps those of a certain ethnic background that are known to be at higher risk. At the end of the day, screening in the urological world is felt to matter and matter substantially. And the guidelines, or it's not really guidelines. This is an arm's reach agency of the government had reached out to our colleagues, the primary care practitioners in both the US and Canada, to say that screening does not save lives. First, in prostate cancer, it probably harms them, they say. And with that came a plummet in the PSA assessments by GPs. And as Dr. Matsumoto rightly pointed out, in February of this year, a publication, or at least a presentation at the virtual genitourinary ASCO meeting, showed that every single state in the United States is registering more cases of men who have incurable disease now at a young age. But what we want to see is that men at risk get screened. And if you find prostate cancer, one hopes that the majority have disease that's localized or early. But unfortunately, as Eddie pointed out, if you don't go through this issue here, you may present at a time when the cat has left the bag and it's no longer curable. So I'm going to sort of go from that point on and then come back to what Dr. Matsumoto pointed out. So let's start with the ones that we hope to catch. That's this group. You go through screening, we find them, and we suspect that in the best of our abilities, these men have disease that is still confined to the prostate, and we don't think that it's outside. Of course, we are limited by technology, and some of these patients, about 20% or so, have disease outside. So these guys have disease that's confined to the prostate, and then how we manage these patients really depends on perceived risk. So as a physician, as a clinician, any of us would say, okay, I'm sorry to say that you've been diagnosed with prostate cancer, but really, unlike other cancers, there's not really much of a discussion in many cancers. You know, it's going to need some therapy or else it's palliation. Prostate cancer, there are many men who may get away with no absolute intervention, just careful observation. But all of that is predicated on assessment of risk. And risk really, all that means is that if I were not to treat this cancer, what is the risk of the disease progressing to metastases and death? If the perceived risk is low or very low, these patients are best watched and not treated, because treatment then, the risk-benefit ratio is not favoring treatment if the risk of progression is low. If the risk of progression is intermediate or high, we generally recommend treatment. And I can tell you that very safely, upwards of 50% of all new cases diagnosed by screening are low-risk patients. And in Canada, where clinical practice is quite sensible, the vast majority of these patients are not treated radically. So to forego PSA screening for fear of over-treatment is not well-founded, at least in Canada. Maybe an issue in other jurisdictions outside of this country, but not here. What about disease that's intermediate or high risk? Well, that requires a bit more consideration. So if you have disease, my spelling went sideways, that's supposed to say early, disease management, these are patients, as I alluded to, we felt that they need treatment if they're intermediate or high risk. And you have lots of options. Those that are intermediate risk, let's say you're elderly or you have lots of other medical problems and we feel that your risk of death within a certain time frame is low from prostate cancer, some of these we observe. But the mainstay of treatment in this population, as long as you have a reasonable lifespan, is either surgery or radiation. I'll come back to these. And of course, we wouldn't be where we are if we did not conduct clinical trials or conduct research and investigation. And it's one of the many things that the UCCRI does. And so this investigative options do exist in patients who don't want to follow what is considered to be benchmark treatments or want to take on a new potential avenue of therapeutic options. Higher risk patients, and these are patients that we say, look, unfortunately, you're presented with a very bad cancer. It doesn't seem to have spread to the best of our abilities by assessment, but no matter what we do here, the chances of recurrence is high. But the mainstay of treatment is either radiation or surgery, often in combination with other treatments or in sequence. That's what I mean by multiple treatments or multi-treatments. These patients will recur in many cases. And the goal shifts from cure to control. If we can convert a lethal disease into a controllable disease in these high-risk patients, we've still done patients a lot of good. So have we improved in the last decade? The statistics that Dr. Matsumoto showed you was sobering. What it showed you was the fact that, you would think that, in the last decade or 2 decades, we should be a lot further ahead, and yet we see rates of metastatic prostate cancer increasing. That is a direct consequence of poor screening choices. But we have done well in other areas. We've come a long ways in understanding the genetic basis behind prostate cancer, and I'll talk a little bit about this. Imaging technologies have changed for leaps and bounds in imaging technologies. Drug advances or pharmaceutical advances, and I'll talk a little bit about this. All of this is going to be a bird's eye view, and some of this may be reiterated by Dr. Kapoor as well. Some of this will overlap, so we don't want to get too granular about any of this, but I can say to you that the armamentarium of drugs that we have today versus what we had 10 years ago even is a dramatic different landscape. Radiation therapy has improved dramatically, and I'll talk a little bit about this as well. And of course, surgical advances. And St. Joe's is probably one of the most active robotic centers in the country in the range of what's done. None of that would be possible without philanthropy. All of us are proud of the work the foundation has done, and now this dovetails very, very nicely with the mission of UCCRI, not just in education and research, but also in advancement of our technologies to our local population. The ultimate goal of which is to prolong survival while preserving the patient's quality of life in a risk-assessed manner. You don't always have to treat. So we'll start off with genetics. What's happened there? What's the big deal? Has our genes changed over the years? No, but what has changed is the assessment that it's beyond just that your brother, your father had it. There are now clearly men who carry certain genetic mutation that puts them at risk for very bad types of prostate cancer, what we call bad phenotypes. For example, the same gene, and the reason I put these 2 ribbons up here, everybody knows the breast cancer ribbon. Well, the blue is the prostate cancer ribbon. You can see here they're holding hands. Why? Because one of the most feared mutations in breast cancer, known as BRCA1 and 2, particularly BRCA2, in prostate cancer results in very, very bad outcomes. And that alone may not be all that useful as a piece of information if we didn't have some therapeutic direction. And there are now drugs that are approved by Health Canada for treatment of men whose treatments have already failed in other therapies who harbor this mutation that results in women having early or prophylactic mastectomies. We've all seen the Hollywood, leading female figures like Angelina Jolie and so Christina Applegate. Well, they had this mutation. Their children as males, if they're male children, will have a 50-50 chance of getting a fairly terrible prostate cancer. And while we haven't got to the stage yet of saying, let's just take the prostate out prophylactically, I think the radar has changed. And that's just one example. There are over 80 described genes that are active in prostate cancer. And these are just the ones we're born with. There's those that your cancer has developed over time, and they right now are subject of additional investigation simply because they're hard to detect. But that time will come as well using a technology called liquid biopsy. What about imaging? And I believe one of the audience members has already posed this question preemptively, PSMA imaging. You know, the days of CAT scans and bone scan, while still the standard of care in this country, hopefully should be nearing a 5-year end for prostate cancer. The technology is clearly in favor of what we call molecular imaging that can find these little hotspots in the bone. And these hotspots, it could be in the bone and lymph nodes, they're often not visible on a conventional CAT scan. This is not yet approved by Health Canada. It's done as an investigational study at St. Joe's and a number of other sites in this province and some other provinces. But it has been submitted to Health Canada and the FDA, both. We are actually further ahead of our American counterparts on this. But in addition to diagnosis and genetics, there's been, as I mentioned, this is a plethora, it's like a tsunami, a wave of these drugs coming at us in the last 10 years, all of which I have to say, when patients, you know, and I hate to say this because it sounds certainly sensationalism, but patients ask about, you know, doctors and, you know, drug companies are in cahoots together, you guys all have the cure. We wouldn't be where we are without the help of our industry partners. And with their investment over the last 20 years on these new drug classes, now we have a range of new, better hormonal drugs, drugs that are oral, drugs that can be taken at home where patients had no other choice. Chemotherapy has improved. There are new classes of drugs, as I mentioned in the last slide. We're looking at possible immuno-oncology or immune therapy. While that's not been so far attractive, it may be coming. I also mentioned, you know, these advanced imaging modalities, as I showed, for example, this is called a PSMA PET scan. You know, this is fantastic for making the diagnosis, and it would open the gates for patients to receive advanced options of drugs as well. But what if we could go after these, whether it was surgical or radiation, or by drugs? That's called theranostics. So that's kind of, if you combine therapeutic and diagnostic, you get theranostic. So if we had some way of targeting these things by drugs without radiation, without direct external radiation, that would be a very attractive option as well. And of course, I would mention it if it wasn't there. And we also have other drugs that don't directly destroy cancer, but help to improve patients' life. And these are supportive drugs, for example, against fractures. Many of these weren't out there more than 10 years ago. When I mentioned theranostics, this is the landscape of a very unfortunate patient who has a PET scan, a PSMA PET scan that I just showed in an earlier slide, whose body is, if you take out the big black blobs here, where basically the kidneys and the bladder, all the other little dots represent metastases. And unfortunately, this patient is riddled with metastases, has failed everything. This study is out of Australia, which is one of the countries in which PSMA is regulated and is commercially available. PSA of 880 with repeated treatments, PSA 93, and finally the PSA is down to 30, and you can see near complete resolution. The remaining blobs are normal and to be expected in the salivary glands and the kidneys and bladder and so on. So this treatment is coming to Canada only as a clinical trial. It is not commercially available, but it's on the horizon, I would say in the next 3 to 5 years or sooner, hopefully. So things are changing for the better, but none of this would make sense if on the front end, we're not screening, or as Eddie pointed out, smart screening, which is published by the CUA, Dr. Rendon. So, you know, if we find spots where there, you know, in this case, there's, you know, literally dozens and dozens, if not over 100 spots here, and we can give the patient a therapy like theranostic therapy. What if the patient only had 1 or 2 spots? Can we still target that? Well, Dr. Kapoor will most likely speak more on this, but radiation to the prostate is what we normally think about when we talk about radiation on prostate cancer. You can also give radiation to painful bone issues. That's just palliative radiation. In the last 10 years, though, there has been a dramatic increase in interest in giving radiation to patients with metastases like these found on PSMA with a therapeutic intent, not just to get rid of pain, but can we actually change or alter the course of disease? And unlike palliative radiation to metastases, this is ablative radiation. You're going in there with the intent to destroy, seek and destroy. And if you can do that, can we improve survival? Well, this is happening, but it's a subject of fairly intense clinical trials. There are clinical trials in this country looking at this. There's also clinical trials outside of Canada, and broadly that is called metastasis-directed therapy. And what's near and dear to our hearts at St. Joe's, and where we need the philanthropic spirit of our donors, is our robotic technology. We acquired our first robot back in 2012, and since then have performed over 2,500 urological cancer procedures on the robot. Our lung cancer colleagues are also using the robot with excellent results. And we also acquired in the last year the newest and best platform out there in robotics, and this is called the Da Vinci Xi, which is getting a lot of use at St. Joe's, but all of this technology is expensive. And presently the provincial government, their contributions, despite St. Joe's showing very good data as to why it should be economically given to us by the government, as it should be to other centers of excellence, has fallen on deaf ears. In every province except for Alberta, this is not funded. And we need to get the message out that this improves the life and well-being of our patients, not just in urology or genitourinary cancers, but across other diseases as well. And so, yes, we have come a long ways, and I'm very proud to have been a part of many of these things, along with my colleagues, many of whom here you see tonight. We've had a lot of industry collaborations over the years, so I'm also keenly interested in ongoing collaborations, but also our surgical work wouldn't be what it is without industry and patient philanthropy. And then to circle back to end where Dr. Matsumoto started, we are now chasing tiny metastases in order to get months and months of survival advantage. Much of this could be avoided with smart screening with a simple rectal exam that Eddie showed a video of. And clearly the patient walked out without crying, as well as a simple blood test called a PSA. The fear of over-treatment, unnecessary treatment, is not well-founded in this country, and it's more of a United States issue. But even the United States, that landscape has changed, leading the U.S. Preventive Services Task Force to change the recommendation in 2018. But we would like to stay on the cutting edge of all of this innovation, research, education, and clinical care of our patients at St. Joe's, and it's and we are thankful to our foundation greatly and the donors that interact with us. So with that, I'm going to stop in the interest of time. We're slated to go until about 8:30, I believe. But I'd like to just quickly introduce Dr. Kapoor. The UCCRI was the brainchild of Dr. Kapoor, who, along with many of his good industry as well as patient donors, put together this idea that has now come to fruition and is actively helping our patients. Dr. Kapoor is a professor of surgery and an international expert on urological cancers, and in particular has a heavy personal clinical and research focus on kidney cancer, and he has held UCCRI patient meetings on kidney cancer. So it's my pleasure to hand the baton to Dr. Kapoor, and he's going to fill all the gaps that Eddie and I missed at this point. Anil.
All right. Well, I want to thank everybody again for tuning into this webinar, basically a patient educational forum on prostate cancer. And first of all, I want to give kudos to my, being the senior guy here, give kudos to my colleagues. They're not really junior colleagues anymore. They're more senior as well, like me, but not as old as me. So Dr. Shayegan, again, has been a pioneer in prostate cancer surgery, as Dr. Matsumoto has been. And I think they're underselling themselves. Really, these two guys, Dr. Matsumoto and Dr. Shayegan, do the most prostate cancer surgeries robotically of any center in Canada. So I think the outcomes have been fantastic, and we're really proud of the innovations that they've brought into St. Joe's and the UCCRI. Dr. Matsumoto has done a great job talking about screening, and I think I would agree with everything he said, is that get your PSA done. The guidelines are very clear, PSA between the age of 50 and 75. And even though there may be some controversy about that, I agree with that recommendation. If you have a family history, even start at the age of 45. Getting surgery or radiation can cure the cancer. And I'm here to talk about what can happen if we're not able to cure the cancer. So I'm going to spend a lot of the majority of time on this one slide, giving the spectrum of prostate cancer journey for patients. So I'm not sure if you can see my pointer there, but really surgery and radiation are where we want to get it at the earliest stage through screening, and then through all the technologies that we've talked about, including PSMA PET and other microtechnologies to find the earliest cancer cell possible. That's really the way to go. And we are offering PSMA PET technology here in Hamilton. So that is available, and we're on the cutting edge of these radiological techniques to find the cancer at its earlier stage. And then once you do find it, if it's there, then the options for surgery and radiation, robotic and radiation surgery through SBRT or CyberKnife surgery, the technologies at the Urologic Cancer Centre are fantastic, as well as the robotic techniques to cure the cancer. But unfortunately, there are some patients where the cancer reoccurs. And then what we give is androgen deprivation therapy. I'll talk a little bit of what that means for those that aren't aware, is that prostate cancer is a testosterone-driven disease. And so in the old days, when I was younger, we would do what's called a surgical castration, which is really just removal of the testicles, which makes all men cringe. But that would reduce the testosterone down to zero. And as a result of that, the prostate cancer would go to sleep and no longer proliferate as a result of that surgical castration. Now, men are attached to their testicles. We don't like to have our testicles removed very much. And so now there's agents that we offer that are called androgen deprivation injections. And these are injections that we'll talk about in the next few slides, but these injections you get in your abdomen or in your bottom every 3 to 6 months is really a medical castration. What it does is this androgen deprivation therapy induces a castration where the testosterone goes down to zero. When the testosterone goes down to zero, the PSA also should drop down to close to zero. And as a result of that, the prostate cancer goes to sleep and can no longer proliferate. And this buys time, as the prostate cancer cannot wake up. Now that's also lasts for a number of years, but eventually the cancer can learn to mutate and can grow without testosterone. So that becomes testosterone resistant or castrate resistant prostate cancer. That means that the cancer is now mutated and the prostate cancer can grow without testosterone. And so the injections are no longer as effective as they were at the initial stages of the disease when the cancer came back. So then now we have a number of new medications that we can offer. These are listed here, and you may have heard about them in the news or in advertisements, but they're called abiraterone, enzalutamide or Xtandi, abiraterone or Zytiga, Xofigo. And these medications are used in the castrate-resistant space to, again, put the testosterone back down to zero so the cancer can no longer proliferate. And we use those in combination with the hormone injections. Many patients ask, well, if my prostate cancer is now castrate resistant and does not require testosterone, maybe I can stop the injections. And the answer to that, unfortunately, is that we recommend the injections as well as the addition of these drugs. And these drugs, that I won't go into in great detail, have prolonged life expectancy in many men in combination with the hormone therapy. And these drugs are pills that can avoid chemotherapy and immunotherapy, and also can prolong life in many patients. So that's kind of a nutshell what androgen deprivation therapy is. Now, these injections that you get, unfortunately, have their own side effects, and many of the patients that may be on the line are on a hormone therapy or androgen deprivation therapy. The side effects can be hot flashes, which is very, very common and disruptive. Can also cause some weakening of the bone, so it's important to take vitamin D and calcium, and that cannot be overlooked. The calcium we recommend is 1,000 milligrams, vitamin D 1,000 as well, and that can keep your bone strong so that when the testosterone is zero, you're not at risk for fractures from the hormone therapy itself. There can also be some cardiovascular side effects of these drugs as well, and so it's important to also have a cardiac assessment on a regular basis while on these therapies. Looks like this slide didn't come out as much as I wanted to, but basically the testosterone monitoring during hormone therapy can help. And so when you get your injections every 3 months, you may notice that your urologist also orders a testosterone level as well as a PSA. And many patients wonder why we do that. We do know that if your testosterone is not zero, then the injections are not as helpful. So your testosterone should be less than 0.7 and close to zero or zero. And your PSA should also be low. And if your testosterone is not zero, then the injection may not be as effective. It may require some switching around of the medication. But the testosterone monitoring is also important to remember as well. So if your urologist is not checking the testosterone while doing the PSA, you can remind them that the testosterone monitoring is important during that. Castrate testosterone is important. And we do know that multiple studies that are listed here, if you want to look them up later on, shows that if you do have these castrate or subcastrate testosterone, you do better as well. You live longer, and the drugs are much more effective. There's different formulations out there. There's leuprolide. There's a number of other ones that we'll go in the next few slides. But all of these hormone therapies are pretty equivalent. There's really not a lot of difference in terms of testosterone suppression with these. And so whatever agent you're on by your urologist, these are all equally effective, and one's not better than the other in general. There are some breakthroughs despite the type of hormone therapy used, and in that case, does require the addition of other treatment or switch over to the other injections to do that. And but we do know that there are some factors associated, which include age and being overweight can also predispose to that. Now, I'm also going to talk a little bit about COVID. I thought many of you may be wondering about COVID and how it affects your prostate cancer treatment. And so these are some of the popular agents that are out there. There's called Eligard, which is, again, a medical castration. There's Lupron, there's Zoladex, and there's a few others as well. And these drugs, again, are basically a medical castration that replaces removal of the testicles, which you no longer do on a regular basis. And now we're giving some of these injections at home to avoid being in the hospital. And if you're not involved in that, we can facilitate that for you through these home injection programs. So they come to your house and give you the injection. You still need to be monitored, however, by your urologist with that PSA and testosterone every 3 to 6 months while you get the injection to make sure that it's working. And these home support programs are very good, where the nurses are very trained to come in with PPE protection, so you're not at risk for COVID during the injection. Same with these pills. I talked a little bit about these pills in the initial slide. They're called ARAT therapies, and they're called abiraterone with prednisone or Zytiga, apalutamide or Erleada or enzalutamide or Xtandi. They can also deliver these drugs to your home during COVID, so you don't have to come in and get them refilled. But again, the monitoring of the PSA and other blood work while on these agents is very important while you're receiving these therapies. Now, one of the members of the UCCRI from the Urologic Cancer Centre, again, this entity that we've created through the generosity of philanthropists, has created this organization, which also includes all of Hamilton, not just the St. Joe's, but we also have Dr. Lalani, a medical oncologist at the Urologic Cancer Centre, Dr. Sebastian Hutt, who is also a close collaborator with Dr. Shayegan, Dr. Matsumoto, myself. When we put out these recommendations, we're quoted worldwide for how to prioritize advanced cancer therapies during the COVID pandemic. And this is all more true now with this third wave, which is being extended and bad news again that it may go on into the end of May or June, and hopefully will end sooner, but we'll have to see what happens as this progresses. And the recommendations are in this document and other documents is that we should still go ahead with the surgeries, especially if you have high intermediate risk or high risk surgeries. Then we recommend that you should not be delayed for that surgery and should go ahead and get it done, despite the risk for COVID. And with a negative COVID test, it's very safe. And we've talked a little bit about Gleason during the course of these two talks, but Gleason is a way to stratify the risk of your prostate cancer. And, you basically look at the main Gleason or the main pathologic criteria of the prostate biopsy. Then you look at the secondary and you add those two numbers together, and anything less than 6 is not an aggressive prostate cancer, and anything 7 and over is intermediate and high risk. If you have a 6 or a 7 with the primary grade 3, you can wait 3 to 6 months quite safely. In fact, for Gleason 6, recommendations for now are in general to avoid any treatment because it may be indolent and not an aggressive cancer. But anything beyond that, we recommend you get it treated. And with our colleagues at St. Joe's, we're able to get these surgeries done even now during the third wave of the COVID pandemic. For the treatment therapies, we also recommend that you have these treatments done during the COVID pandemic, but through these home injection programs. And so we recommend that the ARATs, or those pills that I talked about, or the injections as well, the androgen deprivation therapy, you can keep on these through the home programs and still be monitored through telephone visits or virtual medicine if you're at risk for coming into the hospital, if you're not been immunized. And we're also recommending to avoid chemotherapy because of the necessity to come into the cancer centers for these chemotherapies and the side effects as well during chemotherapies. You want to avoid that and go on these ARAT pills or these injections to avoid that possibility. This is the same for metastatic castrate-sensitive prostate cancer. I haven't touched on what that means for the sake of time, but if we have any questions about what castrate-sensitive prostate cancer is or castrate-resistant prostate cancer, in general, we talk that castrate-resistant prostate cancer means that the cancer is mutated and no longer requires testosterone to grow. So as a result of that, we do require these treatments, and the ARATs, the pills, are what we recommend over chemotherapy during COVID. In a post-ARAT setting, then we'll have to talk about whether the chemotherapy should be reinstituted or considered for patients after these third wave, and hopefully there'll be no more waves after that. So I think I'm going to stop there and take any questions. This is Dr. Shayegan's backyard. During the course of the summer, if you want to come to his backyard here, we'll be happy to host you for a barbecue. Thanks very much for tuning in.
That was great. Thanks, Anil. So for those of you who are still with us and listening, please go ahead and use your Q&A function to pose questions. You'll find that at the bottom panel of your Zoom screen, sort of middle right. But there has been some submitted questions, which I'll just run with our group. So we have questions submitted both in the categories of screening and diagnosis, as well as potentially some surgical questions. So let me flip this one back to Dr. Matsumoto. One question is kind of a broad question. What's the best way to maintain good prostate health? Kind of a general question. Oh, you're on mute, Eddie.
I was gonna say lots of sex.
You're being recorded there, doctor. Recorded.
Oh, sorry. Yeah. That was yeah. You mean, I think this is a question that always gets raised when we're in your clinic. I think Bobby gets this quite a bit. So what can I do to make my prostate better stuff? And I mean, unfortunately, it's a lifelong of, I think, not abuse, but exposures to probably number one thing is diet. The other thing is genetics, which you can change. And just the environment that we live in. And if you can modify any of these factors, then great. I think the biggest place where we can make modification potentially is lifestyle and diet. You mean, is there hard evidence for this? No, not really. It's an area that's been well studied. There've been a lot of trials. Neil Flesher has done a lot in nutrition and diet and looking at prostate cancer prevention. But I think it's all common sense stuff. And I always tell patients, generally speaking, anything that's good for your heart, that's good for your health, is going to be good for the prostate. So everything in moderation, exercise, good diet. I think these are all things to maintain good, healthy prostate and hopefully avoid prostate cancer. I don't know. What do you think, Bobby?
Well, I think also you made a bit of a joke around sexual activity, but in general, that's actually quite true. And we don't have any evidence that it would prevent prostate cancer, but it is definitely good for your prostate health to clear out all those old gucky fluids in the prostate and clear them out on a regular basis, twice a day.
Twice a day.
You know, I gave a warning about, demeanor. We recorded, but that's okay. So, but no, I agree with all of that actually. But, and the point that Dr. Matsumoto makes is, I think, is a good point, that there is really no proven, micronutrient or dietary approach. There was a lot of stuff on antioxidants and, tomatoes and so on and so forth. To date, nothing, but probably a general healthy diet. So if somebody comes out with something miraculous that's not in the body of literature, that would be akin to Donald Trump's hydroxychloroquine. And there is nothing out there that is going to prevent prostate cancer. And I think the more we learn about the genetic changes that you are born with or that you acquire, the more it's becoming evident that, yes, it's a genetic factor, but there's probably environmental pressures that we can't define. All right, I'm going to flip a different question, Dr. Kapoor. Dr. Kapoor is one of the principal investigators on the PSMA trial that we have now, the scan. The question is a tough one. How long does it usually take to move from the PSMA clinical trial to a treatment plan? I assume I'm assuming by that they're talking about stereotactic treatment, but if the question is when do we go from a trial to commercially available, I think that's probably the bigger question.
Yeah, it's a good question. And again, as Bobby is a co-investigator in that trial as well as Dr. Matsumoto, currently the Ontario government has been offering PSMA PET for patients who have progressed or relapsed after prostate cancer or radiation. So we can actually get that PSMA PET done fairly quickly within a few weeks, and then give that information back to your oncologist, whether it be a urologist in any site. Right now, we're offering this for referrals from Kitchener, Waterloo, Burlington, Niagara Falls, all coming into St. Joe's for these PSMA PET. And we're looking to expand that program as well through philanthropy. And so we're always looking for support from our community for this. At some point, the government should fund it for all patients. Right now, they're not. They're offering it through this registry, and we're collecting the data. We actually have almost 800 patients that have been treated with this PSMA, or not treated, but been diagnosed with this PSMA PET at St. Joe's. And with that data, we're hoping to submit that to the government to get approval for all comers, for all patients who need a PSMA PET. So we'll order like a CAT scan or a bone scan on par with that. But right now, it's offered through this registry. And hopefully we'll get that approved for all patients. You want to add to that, Bobby, you ready? Or?
Yeah, no, that's accurate. And then, at the end of the day, Health Canada has to approve the technology. There's a new drug submission, I believe, as of December in front of Health Canada, as well as the FDA. Once it's approved, then provinces just have to work out the money side of things. But frankly, it's cheaper than a CAT scan. So I can't see that this is not going to be a practice-changing technology very soon. It has in other countries, just we're not there yet.
The most amazing thing is that this technology has been able to identify prostate cancer areas that would not be picked up normally by a CAT scan and a bone scan. And in fact, the first 300 patients, we've just analyzed it and reported it at a recent meeting, showing that up to 80% of patients that had a negative CT scan and negative bone scan after radiation or surgery with a rising PSA had some lesion picked up on PSMA PET. So it's a great technology, and it will change patient care and optimize outcomes for patients. Because if you do, as Dr. Shayegan mentioned, identify a small area in the bone or in an area that was not identified on CT scan or bone scan, such as a lymph node, you could do this cyberknife radiation to that area and lower that PSA back down to 0 with that, without the need for more advanced therapies.
And yeah, and cyberknife to those, it's just very, very high dose focused radiation to ablate. Another question is on the MRI fusion biopsy system. Maybe I'll take that one. Does St. Joe's have this innovative and precise equipment? The answer to that is currently no, but we are very actively working with one of our philanthropist donors and the foundation to try to bridge this gap. The gap really is province-wide, it's not national. There are very few hospitals across the entire country that have a clinical platform. So for those that don't know what this is, a conventional prostate biopsy, I would say that in today's world is rather archaic and blind. It's basically a random but systematic sampling of the prostate. This technology is really predicated on the fact that we do an MRI before a biopsy, ideally, find the area of interest and target it. And that requires some fancy software and some capital purchases. We are actively working on it, hoping this is going to hopefully materialize soon for us. It's a priority for the Division of Urology and St. Joseph's Hospital. So this is going to happen hopefully soon. Another question is, if you're on active surveillance, what symptoms should I be aware of?
To add to that, Bobby, I agree with everything you said. And just for the sake of everyone on the line, is right now patients in Hamilton are being triaged off to Toronto, which in order to do that, we have to refer our Hamilton patients to a urologist in Toronto to arrange for a cognitive MRI biopsy. And so that's really not where we should be in Hamilton for these kind of things. So working through the foundation and with Dr. Shayegan to get this MRI cognitive biopsy is really the standard of care that we should offer all Hamilton patients. And so if you're able to support us on this, we'd really appreciate it.
Thanks, Anil. Another question back to Dr. Matsumoto. The benefits of a robotic prostatectomy versus an abdominal approach, which I presume means the classic open approach. Eddie, mute. You're on mute.
You think I figured this Zoom thing out by now, right? Like, holy smokes.
We should teach you about technology.
I know. Yeah, exactly. So just coming back to you, the biggest thing is, you're going from a big open incision to treat the cancer down to very small openings or small ports. So you can imagine, there's smaller cut, there's gonna be less pain. And I think that's the biggest thing. I'll right off the bat, there's gonna be less pain, and obviously there'll be quicker recovery. And along with it, what we found is obviously there's shorter hospital stays, there's less bleeding. Oncologically, I think, we probably have better results. There's no question, urinary function wise, patients do much better with the laparoscopic or the minimally invasive approach, where I think the continence comes back quicker. Partially has to do probably with the finesse and the just a very delicate approach to how we dissect the prostate off the bladder. We're not getting our hands in there and kind of mangling things and just kind of, grabbing things that we don't really know what we're grabbing. It's a real elegant surgery. And I think that really ends up with some really good, what's called functional outcomes. So I think that's the biggest thing. Bobby, you have anything else to add? The big difference between...
No, I fully agree. I mean, at the end of the day, the way I look at all of this is that it's technology that is improving patient experience. We're not taking away by any shape or form from the cancer control. And if the other domains are improved, that's a win-win for all. The only caveat is cost, which is why we constantly have to come back around and, stress that philanthropy underpins everything we do here, because the provincial government has yet to support this anywhere. This hospital has been very generous, but it needs ongoing support. And I think there's another question, Eddie, that what can you expect post-prostate removal? Much of that was already answered. There's another question that was just posed now. And the question is, why would doctors recommend hormone therapy with radiation instead of surgery when a patient has a PSA of 22. You know, I think you got to be careful for us to give clinical advice with very little information, just besides a PSA. In my talk, and Anil also made a reference to this, that, you know, the risk is predicated on what we perceive to be the risk of a patient progressing to metastases and death within his lifetime, weighed against their comorbidities or other medical illnesses. So often the decision as to there is never going to be a trial comparing that combination versus surgery in this population. That the randomized trial just won't happen. So all we can do is compare side by side, and there's always going to be bias in the patient populations. So that depends on the patient, their choice, the advice they were given. Suffice it to say that there can be substantial overlap with fairly decent outcomes in either direction. There's pros and cons. And so, I can't say that it's wrong or right. It's well within the standards of care to recommend radiation with hormonal therapy for up to 3 years in a high-risk setting like that. So I hope that answers that question.
Just to add to that as well, in addition to Dr. Shayegan's comments, is that what looks like this would be called sort of high-risk prostate cancer or advanced prostate cancer. And in general, there is some controversy about the standard of care for that. And so with the PSA of 22, again, without knowing the specifics, in general, there's a recommendation that radiation may get a wider field than a localized field with surgery. So that's where sometimes radiation is recommended for what's called high-risk prostate cancer, but surgery also has a great role with that. So what the recommendations are is that you get an opinion from a urologist, such as Dr. Shayegan, Dr. Matsumoto, or myself, as well as an opinion from a radiation doctor, so you can get a balanced view about the options for treatment, not just whether it be radiation or surgery, depending on the scenario.
So we don't have any other posted questions or outstanding questions. Maybe a 5-minute around the panel. If maybe we should talk about what we think has impacted our patients in the last 10 years. I'll start with me. I think everything I mentioned has changed everything for me. I think it's been a great disappointment seeing the response by various government agencies feeling that they're acting in the patient's best interest, but likely there are geopolitical interests behind all of this. And I think the lack of, or the massive drop in screening is a detriment to our patients. That's on the negative side. On the positive side, everything else, and when it comes to a patient with cancer, that has improved dramatically in many of the genitourinary cancers, and prostate being one of the big ones in the last 10 years. So I think we're very hopeful. We're nowhere near a cure. We can't prevent. We should find early, watch the ones that need to be watched, treat the ones that need to be treated with the best treatment possible. And hopefully, we can climb that cost hill with our donors and acquire what we need at St. Joe's. So Anil, yourself maybe?
Well, I have a couple of things I think are very impactful. So I tend to, again, prostate cancer has been ubiquitous, and being the old guy in the block here with this panel, I remember when I first started practice doing prostatectomies on Gleason 6 prostate cancers, and we know now that that was a wrong thing to do. We just didn't know back then that Gleason 6 prostate cancer is not aggressive and doesn't need to be treated. So one of the things that I've observed over the course of my career is that a conservative approach to prostate cancer is not unreasonable. And one thing we do know is that prostate cancer is very ubiquitous. So one stat I like to quote patients is that 80% of 80-year-olds have prostate cancer, 90% of 90-year-olds, and if you live long enough, you may get some degree of prostate cancer in men. But not all that prostate cancer needs to be treated. So we have to choose and find out which prostate cancers are clinically significant versus clinically insignificant, which patients may pass away from other causes besides prostate cancer versus prostate cancer related death. And so that's still our challenge, even now, trying to figure out which prostate cancers are going to be significant in a patient's lifetime versus not significant at all. And again, having a mature practice, I have hundreds of patients like Dr. Shayegan and Dr. Matsumoto do that have prostate cancer Gleason 6 that has been treated conservatively over many, many years without progression and doesn't need to be treated. So now we know that, and as we get more advances in this, we'll find out those patients that don't have to have treatment versus those that do need to have treatment. And the second thing I think is very important and coming up that Dr. Shayegan has a particular interest in that I do with Dr. Matsumoto is the genetic basis of prostate cancer. We haven't spent a long time on that today, but like breast cancer, BRCA1, BRCA2, and ATM, these mutations that some patients may have, if you have a family history of prostate cancer, if you have a prostate cancer at a younger age, and advanced or metastatic prostate cancer, many times there is a role for genetic testing that we're trying to roll out in Ontario to see if you qualify for some of these, qualify for some newer drugs that we haven't talked about yet, but drugs such as olaparib and so on, that maybe what's called a PARP inhibitor may help your prostate cancer journey as well. So the genetic piece in prostate cancer testing, I think, is getting more airplay in Ontario and around the world. And I think that's also the next frontier for prostate cancer treatment.
Thank you. Eddie, some closing comments?
Closing comments, my thoughts on prostate cancer. You mean, I echo a lot of the things that Anil said about, following these patients that have, low-grade cancers. I think that's something that we do. I think it's a good way of minimizing the morbidity and even mortality of some of the treatments that we have. And I think Canadians have been leaders when it comes to managing these patients with these low-risk cancers. But having said that, and the more my practice matures, I start realizing it's the young guys or the ones that have many years ahead or longevity ahead are the ones that could potentially suffer. And I think that's where we have to identify is the younger men that are at risk. And this is where I think we can make the biggest impact, where we can do surgery or the radiation, or more importantly, prevent the late stage disease or presentation of late stage diseases in this population. So once again, stems back to my talk about screening men that are at risk. And hopefully the younger you are, the greater risk you have of dying of cancer. I agree with Dr. Kapoor. If you're in your 70s or 80s, you're diagnosed with cancer, guess what? You're not going to die of that. You have a greater chance of dying of something else. But it's a different story. Even if you're 40 and you get diagnosed with Gleason 6 cancer, there is a good chance you still may die of that cancer. So I think age, longevity is very important to consider when you're talking about prostate cancer. And the other thing I want to comment, just my practice. I see a lot of patients PSA. Probably one of the largest PSA practices in our group here. And I think improving the diagnostics and Dr. Kapoor alluded to the fact of the MRI fusion biopsies. I think that's something that we really should strive to get in Hamilton. And I think if we can get support for something like that, a program at St. Joe's, I think we go a long way in helping men with prostate cancer and improving our battle against prostate cancer. So I do feel pretty strong about getting something like that in Hamilton, rather than once again sending patients to Toronto. We've tried to send patients, and they actually reject patients from Hamilton now in Toronto. So I think we need to kind of fend for ourselves and really focus on getting an MRI fusion in Hamilton, hopefully at St. Joe's.
Thanks very much, Eddie. So I think with that, we're about 10 minutes early. I'd like to just take a quick moment to thank all of you guys for taking the evening and joining us. We hope to hold more of these events in the future, just to share the activities going on at St. Joe's, some of our new achievements, hopefully new acquisitions over time. Perhaps next time we'll have a little video of our new biopsy machine. But at the end of the day, we all strive to make this a better world for our patients. And we owe a lot of thank you to our donors and our supporters and our collaborators and our support staff. So with that, I just want to bid everybody a great night until next time. And thank you to the whole panel here, Dr. Kapoor and Dr. Matsumoto, the CUA, and our background support. Thanks very much. Good night.
Good night.
Good night.